So I'm going to talk about whether the benefits of empagliflozin vary in different types of patients. I talked a bit about that yesterday in terms of frailty. Today I'm going to talk about that in terms of other baseline characteristics, including some of the slightly more controversial findings from EMPA-KIDNEY. I won't spend too long on this if you've seen all of this before. EMPA-KIDNEY was a randomized trial of empagliflozin versus placebo in 6,609 people with and without diabetes, with a primary outcome of cardiovascular death or kidney disease progression, as is commonly used in many of the CKD progression trials nowadays. These were the baseline characteristics. So average age 63, 1/3 women, more than half without diabetes in this trial. And this trial had the lowest entry, both EGFR at 37 on average, with a third of people with an EGFR less than 30. And also the lowest urine albumin-creatinine ratio of the CKD progression trials, with a median of about 300 milligrams per gram, and about half of patients having less than 300 milligrams per gram, so falling outside the macroalbuminuria range. And 70% of the people had a non-diabetic cause of chronic kidney disease in the trial. Overall, looking at all 6,609 people, the primary outcome was reduced by 28%, which was highly statistically significant over a median follow-up of 2 years. Often when we do trials like this, the first question we get asked is, well, what about patients with characteristic X or patients with disease Y? In other words, when we get into subgroup analyses. For those of you who aren't familiar with looking at or analysing subgroups, it might just be worth explaining these plots to you briefly. So this is the primary outcome by kidney function at baseline. So you can see the categories of kidney function on the left-hand side. The point when you're looking at these sort of subgroup analyses is not to look at each individual subgroup and look at its confidence interval and say, well, does it work in people with an EGFR less than 20? And to conclude, say in this example, to think that it does not because the confidence interval crosses the line of unity. That would be the inappropriate way to look at subgroups. The better way is we have the overall treatment effect here at the bottom. That's what the trial was designed to test. And then what we do is we look and ask the question, well, in these subgroups, is there any evidence that the effects in that subgroup differs from that overall effect? And you can sort of look down these squares and visually you can see that they all pretty much line up. And you can do a statistical test, which shows that there is really no evidence at all that the benefits of SGLT2 inhibitors are modified by baseline kidney function. Now, if you're still awake at this time in the conference, you might have remembered that I told you that the entry criteria for the trial went down to an EGFR of 20, and yet here I am showing you a group of people with an EGFR less than 20. That's because eligibility was assessed at the screening visit. After the screening visit, all the participants went into a 2 to 3 month run-in period where they received placebo empagliflozin, and then they were randomized at the end of that. And it's the EGFR at the randomization visit that I'm showing you here. So some patients qualified for the trial with an EGFR of 20 or more, but 3 months later had an EGFR of less than 20. So it's quite remarkable that the benefits of SGLT2 inhibitors really do extend really quite far down, almost into stage 5 CKD probably. So there's a question about, is it ever too late to start? So that was the result by kidney function. When we started the EMPA-KIDNEY trial, there was actually very little data on SGLT2 inhibitors in people without diabetes. Clearly they were invented or developed as a treatment for diabetes primarily, and therefore the first trials of SGLT2 inhibitors were in people with diabetes and its complications. So the first trial in chronic kidney disease, the first large trial, was the Credence trial, and that was exclusively in people with diabetes. Then other trials got going. So the DAPA-CKD trial, which was going along about the same time as EMPA-KIDNEY, finished a bit before we did. And EMPA-KIDNEY sought to extend the evidence to people without diabetes. The reason for that being that we recognize that the way these treatments might work, and I'll show you bit of talk more about this later, but they may work on the final common pathway for chronic kidney disease. So they are not necessarily disease specific. But once you have reduced nephron number and hyperfiltration, these drugs may help mitigate the risks of hyperfiltration and do that regardless of the cause of your kidney disease. So there was a lot of interest as to whether they might work in people without diabetes, but also a bit considerable uncertainty. So our efforts to recruit a large number of people without diabetes were to address that. Many years ago, that was seen as a bit of a risk. Nowadays, I think nobody bats an eyelid at it. But here is the results by albuminuria, and this is the results that generated some of the controversy that I'm going to talk about now. So here again, we have the baseline categories of albuminuria. I'm afraid these are in American units. If you work in milligrams per millimole like we do in the UK, you can just take the last 0 off the end of this. But here, so this is effectively normal albuminuria, microalbuminuria or macroalbuminuria, or as KDIGO calls it, A1, 2, or 3. And here we have the effects on the primary outcome by baseline albuminuria. And here you can see the squares don't really appear to line up. And when we do the statistical test of that, we see our eyes maybe aren't misleading us. It is what I might call nominally significant. So it's less than the p.05 threshold. That's a bit of an arbitrary threshold, but it is less than that. So it's a bit harder to persuade you probably that SGLT2 inhibitors from these data work regardless of how much baseline albuminuria you have. What I would point out though on this slide is that if you look in the people with very little albuminuria, as we would expect, in only 2 years of follow-up, very few of those people actually went on to have a primary outcome, so lose a substantial amount of kidney function or die from cardiovascular disease. Only 80 events in that group. So there's considerable uncertainty in that group. So I wouldn't be too definitive about anything based on this slide. This, unfortunately, is an inevitable consequence of when you do a trial in CKD progression, is that the people at highest risk are going to be the people who have the most events. And particularly if your trial ends up stopping early like this one did, you're not going to have very much information in terms of categorical outcomes. Did the patient have kidney failure or not, for example, during the trial? So we're slightly limited by power. So that's where some new analytical methods, or relatively new analytical methods for trials, come in quite handy. And I'll just talk a bit about the methods here. So EGFR slope analyses are something which are relatively new in trials, or at least to be used as a focus of trials. Although obviously for nephrologists, we're completely used to this. This is probably what we do nearly every time we see somebody with CKD in the clinic, is we plot their EGFR or their 1/creatinine over time, so we can see how fast they're progressing and maybe give them some idea about when they might need to think about kidney failure treatment. But when we look at these slopes, this is a typical slope from you can see on the right-hand side here, from an ACE inhibitor trial or an SGLT2 inhibitor trial. So you know when we start people with ACE inhibitors that you get what we might call an acute dip. So in the days, hours, days, weeks after you start the drug, the GFR might dip down quite a bit. And then after that, you hope that the progression might slow. And we compare that with what happens in the placebo group, which is just a remorseless, steady decline. But this gives us, analytically, this gives us a bit of a headache. The acute dip creates a bit of a headache for us. So we can talk about two different types of slope here. We can talk about the total slope, which is from right from the beginning, before you start the drug, right to the end of the trial. Or you can talk about what we call the chronic slope, which excludes that acute dip and just starts counting at the first measurement after that acute dip has occurred in EMPA-KIDNEY. That was 2 months after randomization. That was the first time we checked their kidney function again, and just go from 2 months onwards. And that's the chronic slope. Now, the big advantage with slope analyses is that they are statistically incredibly powerful compared to dichotomous clinical outcomes. As I showed you before, we only have 80 outcomes in people with normal albuminuria. However, every single patient in EMPA-KIDNEY has a slope. You can always measure a slope in a patient, and therefore you have a lot more information. And so we can start exploring subgroups with more confidence. Slopes are becoming accepted by the FDA and other regulators as a potential surrogate for CKD progression. I'm not sure I would go so far as to say they can replace it, but they can be very useful in this situation when you want to explore findings from other parts of the study. And when you compare the slopes, it's thought that if you can reduce the slope by 0.5 to 1 mils per minute per year, so if you started at 5, take that down to 4.5 or 4, that is thought to be considered clinically meaningful based on projections which have been done from large meta-analyses. But I just want you to remember that 0.5 to 1 mil per minute per year difference in slope. Before I get there, I just want to say what the slopes I'm about to show you are almost exclusively going to focus on chronic slope rather than total slope. And the reason for that, although there's some publications out there you might be familiar with saying that total slope correlates better with kidney failure, that's probably an artifact of the studies from which that outcome was, or that conclusion was derived. And that these were most of these were relatively short trials, say 2 or 3 years long on average follow-up. And total slope probably does correlate better with your risk of kidney failure over 2 or 3 years. However, when I'm seeing patients in clinic, I'm frequently not very interested in trying to know what's going to happen in the next 2 or 3 years. Frequently, I'm more interested in knowing what's going to happen in the next 5, 10, 15 years with the patient I'm about to see. And in that case, as you can see from this plot here, actually chronic slope may well be more useful to predict long-term outcome better. So short-term outcome, total slope might be useful, but for longer-term outcomes, chronic slope is probably better. So here are the results from EMPA-Kidney then. This is the placebo group, a nice, pretty much straight line, going down at 2.75 mils per minute per year on average. So progressing, not particularly fast, but still progressing. And then this is the group we gave empagliflozin to. Here's the acute dip, as we predict, not very big, only about 2 mils per minute on average, about 6%. So not a very big dip, certainly not anything like you get with ACE inhibitors in some patients. But there's clearly an acute dip. But then after that, a flattening of the chronic slope. So if you then compare the chronic slopes, in EMPA-Kidney by pure fluke, we actually halved it. So it went down from 2.75, it went down to 1.37, which gives you a difference of about 1.37. Remember, I told you that what's thought to be clinically meaningful is a difference of 0.5 to 1. This far exceeds that. So clearly an important difference, as can be seen from the primary outcome of the trial that I showed you earlier on. So now we can use these slopes to look at patients depending on their baseline albuminuria. Because we've got so much more power, statistical power with using these slopes, we can break down albuminuria a bit more finely. So rather than just 3 groups now, I've got 5 groups here going down the left-hand side. And I'm just going to talk through this plot slowly for you. I hope you can read it. But these are the progression rates in the placebo group. And as you expect, people with more albuminuria progress more rapidly. So in the largest group here with an albumin-creatinine ratio greater than 2,000 or more than 2 grams per day, losing kidney function at over 6 mils per minute per year, compared with people with very little albuminuria progressing at less than 1 mil per minute per year. So that's what happened in the placebo group. This matches the observational epidemiology very well, which is always reassuring. And then this is what happens when we gave those people empagliflozin. And you can see that we slowed the chronic slope in all of these groups of patients. So that's the first thing to say, is that in all patients, the reduction in slope was highly statistically significant. There is again a trend, as we saw before with the dichotomous clinical outcome. So albuminuria does modify the effect of treatment, but it does not, from these data, it does not remove the effect of treatment in the people with the lowest albuminuria. In fact, in people with very low albuminuria, you can see here the people given empagliflozin, their rate of progression was actually consistent with 0. We effectively stopped progression in that group. Now, the effect on chronic slope, the absolute effect is smaller in people with lower albuminuria, and it gets bigger as albuminuria increases. But just bear in mind that the people in the lowest albuminuria group were only losing kidney function at 0.9 mils per minute per year. So actually that is a ceiling effect, if you like. You couldn't slow them down any more than 0.9. So there's no way you would ever be able to see what we saw in the highest group, which was a 1.8 mil per minute per year difference, because that would be to turn their kidney function backwards and make it start improving again. And SGLT2 inhibitors are good, but I'm certainly not here trying to persuade you that they make people's kidneys actually get better. They just slow the rate it gets worse. But that's because we're looking at this on an absolute scale. So absolute scales are very useful. I showed them to you yesterday in the frailty analyses, but they do suffer one problem, is that they are a product both of the rate that things are going on in the placebo group multiplied by the proportional effect of treatment. And it's actually the proportional effect of treatment that is probably more useful to think about. So that's what I'm going to show you now, which are on these relative difference. So this is where we just look and see, we've taken, say, 0.88, we've taken it down to 0.11. What is that in proportional terms? And you can actually see that people with low levels of albuminuria actually have the largest proportional effect of treatment. So an 86% reduction in their slope. It's not very big in absolute terms, but in relative terms, that's pretty impressive. Again, there is a very strong evidence, the trend here, but this time it's the other way around, in that the greater your albuminuria, actually the smaller the proportional effect of treatment. But again, in all groups, importantly different and statistically significantly different in all groups. So does albuminuria modify the effect of SGLT2 inhibitors? Yes, it does. So people with low levels of albuminuria benefit from SGLT2 inhibitors. In my opinion, yes, they definitely do. We couldn't detect it even in a large trial with 6,500 patients with just 2 years of follow-up. But if we had followed these patients up on treatment for, say, 10 years, then we probably would have started to see benefits in that group as well. So I hope I've persuaded you that you shouldn't be using albuminuria to guide your treatments, whether to use an SGLT2 inhibitor or not, which is not in alignment, I have to say, with the current KDIGO guidelines, but we're working on that. Just as I get close to the end, this is what we saw in people with different types of diabetes. And what we did have in EMPA-KIDNEY, unlike any of the other trials, is we did have a small group of people with type 1 diabetes in the trial. This is currently not a licensed indication for SGLT2 inhibitors. The major side effect of SGLT2 inhibitors is ketoacidosis. People with type 1 diabetes are particularly vulnerable, and other trials in that population have shown that SGLT2 inhibitors do increase that risk. But we saw that actually, whether you have type 1 diabetes or type 2 diabetes or no diabetes, the effects of study treatment were pretty much the same. So that actually, this has led me in my clinical practice. I'm not making recommendations for yours, but I do use SGLT2 inhibitors in people with type 1 diabetes who are progressing despite all other best medical therapy. What I do insist is that they have access to a ketone meter so that they can monitor their ketones when they feel unwell. And then I give them advice on what to do if that happen. And then finally, looking at different causes of kidney disease. So we asked all the participants as they went into the trial, what was the cause of their kidney disease? We asked their investigators to confirm that or correct that if necessary. And then we lumped them together into some fairly broad categories. So we've got diabetic kidney disease, glomerular diseases, hypertensive or renovascular diseases, and other diseases. And you can see that the effect of treatments, again, whether you look on the absolute scale or the relative scale, was very consistent here. So it didn't seem to matter what the underlying cause of kidney disease was. So it doesn't matter whether you've got diabetes or not. It doesn't matter what the cause of your kidney disease is, you benefit. I do have to point out we did not recruit people who had kidney transplants, and we did not recruit people with adult polycystic kidney disease, both of which I regret now, but that's hindsight for you. Now, this is the long set of my slides, just in case I needed to fill in for Vivek. So I'm afraid I'm going to zoom over all of this. You can ask me about this later. This is what happened when we followed people up for 2 more years. And I think with the clock going yellow, I'll just finish there. And as yesterday, thank all of the collaborators who made this possible in the 240 hospitals around the world, but particularly the 6,609 participants. And thank you for your attention.
The talk that I've been asked to give is about digital health and acute kidney injury, and to talk about its current status and challenges in clinical practice. So there are 2 terms that we have to contend with. The first one is the one that we are more familiar with as nephrologists, acute kidney injury. And this slide shows you simply the pathway to diagnosis and management of acute kidney injury. And what I want to actually highlight here is that acute kidney injury can be identified or encountered in two settings. One is, of course, in hospital, where someone who's already admitted to a hospital develops acute kidney injury as a result of maybe a therapeutic insult or a worsening of disease or nephrotoxic administration and so on. But the other type of acute kidney injury, which we see more commonly in low and lower middle income country settings, is the one that develops in the community, where someone develops some insult that will eventually go on to affect the kidney in the community. For example, a complicated pregnancy, a snake bite, a tropical illness, or a diarrhea, etc. But now, the current evidence-based guidelines that we have are largely focused on hospital-acquired acute kidney injury, and the community part of it has been neglected, and we'll come towards towards the end of my talk. And the second term that we need to familiarize ourselves with is digital health, which in a broad sense is the use of information and communication tools in medicine and other professions to manage illness and health risks, and of course to promote wellness. How do we improve clinical care digital approaches? There are a number of terms that are out there, and the number of the terms is actually increasing as we go on. Some of those are listed here on this slide, and hopefully we are all familiar with most of these. For example, electronic health records, I'm sure most of us are using in some way or the other. Wearable medical devices are becoming increasingly common. I'm sure most of you have either a smartwatch or a Fitbit device on your wrist, which is measuring something or the other in our body, which has medical relevance. We also use continuous blood pressure monitoring. Omics technologies generate a whole lot of data. And then software as a medical device. This is an interesting one. And so any software that can serve as for any medical purpose, for example, a software that monitors our heart rate, a software that monitors our blood sugar and thereby adjusts the speed of the insulin pump, a software that can analyze imaging data, and so on. Then we have clinical decision support system, which is nothing but the algorithm that we are so familiar with, which are now coded into an electronic format and loaded on a device, and thereby giving automated outputs based on the inputs they receive. The use of the brain power of someone is not required. Rather, the computing power does the job. Mobile health is, of course, use of any mobile device for healthcare. And analogous but somewhat different is telemedicine and telehealth. Data analytics is important because it is the continuous analytics of the data that allow us to inform how we develop our various digital health solutions, and also how we refine it as we go along. We now live in a world of artificial intelligence and machine learning, and almost on a weekly basis, some new updates are being released to the various large language model platforms. And eventually, we are hoping that we will be able to reach an era where we will be able to deliver digitally enabled therapeutics to our patients. So what are the potential benefits of digital health? At the very minimum, digital health should be able to improve access to healthcare to people who live in a remote location, or people who, for some reason, are not able to come to a physical hospital setting. It should also ideally be able to reduce inefficiencies in the healthcare system, improve quality of care, and reduce errors. It should eventually, I hope, help us develop new models of care which are different from the physician-centric models of care that we currently are used to and grew up on, and that the model of care will be different maybe 10 or 20 years from now than what it is today. Our hope is that all this will lower the cost of healthcare, although the healthcare industry never likes reducing the cost of care. And ideally for the patient, the healthcare becomes more personalized for prevention, early diagnosis, self-monitoring, promotes self-monitoring and self-management. And eventually the care becomes really tailored to the individual, what we call bespoke care, rather like the bespoke suits that many of you perhaps are wearing right now. We know that the global digital health market is growing continuously, and this slide shows one projection in the growth of a digital health market and the various components of digital health market. You can see that the biggest chunk is the telehealthcare, followed by mHealth and healthcare analytics, and then, of course, digital health systems. Now, let's come to the marriage of the two terms, digital health and acute kidney injury. And I'd like to draw your attention to this consensus statement published a couple of years ago, or rather last year, in Nature Reviews Nephrology, which was the result of an output from Acute Disease Quality Initiative Work Group's 27th meeting, and a number of concepts that I'm going to present to you have been taken from this report. Now, for us to think about the potential settings for the use of digital health in acute kidney injury, as I said, we have the hospital setting, of course, but we also need to think of how we can use it in the community, both before and after the development of acute kidney injury. So conceptually, the range can start from risk stratification, where someone doesn't yet have acute kidney injury, but maybe at increased risk of developing the condition, to early recognition of acute kidney injury, care delivery, hopefully personalized care delivery in such a way that optimizes recovery of that individual. And of course, once they recover, they also require follow-up care. So digital health should be able to help us with that as well. Now, here is a slide that shows us really the summary of what do we know about the potential influence of digital health on outcomes in acute kidney injury. So the summary of evidence shows us that acute kidney injury alerts improve early detection and help us prompt management of acute kidney injury. We also know that machine learning or AI-based risk prediction models might, and here the emphasis is on the word might, improve the identification of patients at high risk of acute kidney injury who could benefit from tailored surveillance on primary prevention. This is something that remains to be proven yet. And finally, there is insufficient evidence to show the influence of digital approaches on AKI outcomes across the care continuum. This slide shows you the summary of a number of papers which are listed at the bottom of the page, and the essential summation of the evidence suggests that acute kidney injury clinical decision support system alerts allow us to identify acute kidney injury, all stages. It helps us improve documentation of acute kidney injury and improve the recognition and response time in critically ill patients who are receiving nephrotoxins, help us with reduction in the use of nephrotoxins. But the impact on AKI duration and progression, length of hospital stay, and the need for kidney replacement therapy is less clear. And last but not the least, this focus on achieving high sensitivity can lead to a high number of false positive alerts, which can cause alert fatigue and might dilute any improvements in outcome. There are a number of clinical trials. Many of them have been led by Dr. F. Perry Wilson, but I'm going to show you just this one meta-analysis in which these authors looked at a number of trials, both randomized and non-randomized clinical trials. And what they've shown is that use of acute kidney injury alerts increases the number of nephrology consultations, helps with AKI documentation, and helps reduction of NSAID exposure. And on the bottom right there, apologies for the wrong labeling, it is on AKI progression and help with the reduction in AKI progression as well. But unfortunately, they don't have any impact on any meaningful outcome. For example, they don't reduce the length of stay in hospital of these individuals, or they don't help reduce mortality of patients with acute kidney injury. Now, there are a number of limitations of the current studies. Most of them are retrospective and observational in nature. We know that randomized clinical trials are the best type of studies for testing any intervention. And so we need to do more of those, especially in low and lower middle country settings. They are also limited by the volume and scope of data. But one challenge has been that the researchers have looked at easy kind of endpoints. For example, AKI recognition and improved response rather than important outcomes such as mortality, length of stay, etc. And of course, finally, we have a lack of robust validation, especially in different healthcare settings. Now, let's look at the implementation cycle of digital health and acute kidney injury. We start by exploring the phase of exploration, right, where we identify the need and define the context. We map out the resources and the local structures and the processes in the healthcare system. And this is the phase where we settle on the measurable outcomes that we are interested in and put in place guardrails which will minimize bias and promote equity. Once all that has been done, then we deploy the digital health solution by appropriately aligning it with the healthcare system and put them in appropriate context of the locally available resources, which may be technological, personnel, financial, administrative, educational, etc. Once it has been deployed, then it, of course, needs to be implemented, and implementation will require stakeholder engagement and a continuous process of quality assurance and performance improvement, because it is only by the process of reiterative improvement that we come to a perfect tool. Once we have done this, the knowledge has been thus generated needs to be transferred for broad implementation. And here we need to define the scope of dissemination, list out the lessons that have been learned from the initial implementation. What are the contextual factors that impacted implementation? For example, what worked, what did not work? If something worked, why did it work? If something did not work, why did it not work? And once we have answered those and refined the tool, then we will go ahead and adapt the tool. But as we are doing this, we need to be mindful of a number of barriers which range from ethical, legal, and social barriers. There can be barriers around usage as well, who can use it, who cannot use it, and digital literacy, and so on and so forth. So then just coming back to this point is that there are a number of areas with potential impact by digital health solutions across the continuum of AKI, which we discussed right in the beginning of this talk. They can be applied in the community, shown here on the top left. They can be applied in hospital, shown here on the right side. And they can be applied once the patient has been discharged from the hospital or has come out of the acute care need. And the various parameters, such as stratification, recognition, how do we tailor the response, and how do we guide AKI recovery are shown in different boxes in these three particular situations. We also recognize that we can actually get data from a number of sources. So every individual will have a digital health profile, which will consist of data of that patient himself or herself collected through wearable, through mHealth, health systems data, through health information technology and telehealth. And of course, they need to be put in context of population data as well, and community data for use of community alerts as well, public health, social determinants of health, and so on. Talking of social determinants of health, we will be remiss if we, as I said, we don't discuss the context of the environment that you and I work in, which is the LMIC environment, where there is a lot of acute kidney injury developing in the community. So in the community, there is a vast unmet need. There is a large undiagnosed and untreated population. There is inadequate workforce to take care of these people. We obviously, as nephrologists, focus on late-stage curative care models such as dialysis, continuous renal replacement therapy, and so on. And we have to admit that there is a great variation in the quality of care, and the care is high cost relative to the ability to pay. And this is where we can actually leverage digital health technologies. And digital health technologies can take the form of this kind of mobile device that you see, this frontline healthcare worker who is not a physician, but a non-physician healthcare worker. And she is intently looking at this device with someone peering from behind her as well. And these devices are now loaded with clinical decision support systems, with prompts, with training modules, etc., that allow them to go out in the community and identify individuals at high risk of a health condition for which that particular solution has been developed using the implementation cycle that I described to you a few minutes ago. They can actually go to remote locations and meet with the individuals here. Shown on the left, that individual, and on the right side is the health worker. She is querying the individual and identifying their risk status and so on. This is from a different context, but just to make the point, that these community health workers are often able to identify a high-risk condition better than a physician. This is a study that we published now more than 10 years ago, and since then our work has evolved. This work has not been done in acute kidney injury space, but more in chronic disease space, but there is no reason why similar principles will not be applicable to acute kidney injury. This is exactly what was done by the International Society of Nephrology 0 by 25 initiative. And in the 0 by 25 initiative, the goal was to develop a system which allows us to, or not us, but the healthcare system to identify people at increased risk or early stages of acute kidney injury in the community and to intervene early. And the way this was done was by development of a clinical risk score coupled with point-of-care testing for serum creatinine. And now we can also test for proteinuria. And using that information, developing a protocolized management plan in consultation with the local healthcare system, with the goal of improved recognition and management of acute kidney injury. I'll draw your attention to this paper shown here, published a couple of years ago in PLOS Medicine, where this study was implemented in 3 countries and showed that, yes, it was feasible to do so. Now, what we need to do in the next stage is to do a properly designed, powered, randomized clinical trial to show that, yes, it improves clinical outcomes. Now, jumping many steps ahead, now let's look at the cutting edge of technology. There are other things. We talked about point-of-care devices. Advances are being made on the cutting edge of how these can be done. And this is an example of a device that is based on your eyeglass. It's a kind of fluidic device which can measure various components in the tear film. And one of the components that can be measured is the creatinine values in this tear. This has been done. Actually, it is shown, as you can see from the figure on the right, that creatinine value can be measured there in a reliable manner, and that it is quite consistently similar to the serum creatinine value. So what it does is that it allows us to have a non-invasive way of monitoring creatinine in a continuous manner, because that is what we need in someone with acute kidney injury. In chronic kidney injury, you don't need very frequent monitoring. You can monitor once in a while. But when acute kidney injury happens, we perhaps will be better informed by a more rapid or frequent measurement of kidney function. And last but not the least, as a matter of curiosity, we are going to this situation where Precision Health Smart Toilets, which has a pressure sensor, motion sensor, has a stool camera, anus camera for various things. But importantly for us, there is a urinalysis strip in it, and it has a uroflow camera as well. So urinalysis strip will allow us to pick up abnormalities such as proteinuria and hematuria, and uroflow camera will be able to pick up the urine volume, which are all helpful in management of acute kidney injury. So it looks like science fiction. But my dear friends, let me conclude by again repeating that digital health tools offer a unique opportunity to enhance the care of patients with acute kidney injury. And the digital health tools are continuing to evolve, but we have to be mindful of the need to make these solutions context specific. Something that has been developed for UK or US may not apply in Sri Lanka or India. Right? And they need to be developed and tested in real-world settings to examine the impact on relevant outcomes. And finally, the implementation will need to be monitored for unintended consequences such as false alerts, and not last but not the least, introduction or exacerbations of inequities in care delivery. It's fair to say that any time that a new, more technology-intensive type of solution is introduced in the society, it increases inequity, because people with greater degree of resources, more wealth, more access, always will have first access or first dibs in it, as compared to people who will be less well off, but perhaps.
When I received this topic, I was a little bit shocked because they asked me to talk about AI and advanced technology in kidney disease. Because normally I'm a lupus person doing a lot on basic science, translational sciences. So, normally I usually wear a very decent suit. So today I have to pretend as an IT person. So in a t-shirt, in an IT way. So, right. So I'll just share my thoughts because, I also did a little bit of research on how we employ AI in managing some of our kidney diseases. So I like this quote very much. Research is a formalized curiosity. It's poking and prying with a purpose. So you can't just probe. You can't just investigate out of nothing. So it's very, very difficult. You have to have a certain... But using artificial intelligence and advanced modeling, there are several prerequisites. And in fact, you need a very good clinical link or a very nice research question. This is always important. As I alluded in my first slide, you need lots and lots of data. You have a large number of data. You need to have very trustworthy data. So what are trustworthy data? So in a database or even electronic health records, as alluded by Professor Vivek, we have lab values. Drugs, these are things that cannot be wrongly coded because in many of the countries, these codings or these diagnoses are being coded by the interns or very junior residents. They have no interest in coding it correctly. So trustworthy data are lab values, drugs, etc. You need some good ground truth. So that would be very nice clinical events and outcomes. Of course, you need to have lots of collaborations with other people. So many of the stuff, which I'll show you later on, are not completely done by me, but I usually pose a question to them. But you need a lot of very good statisticians, computer scientists, and also various other collaborators to do all these researches. And of course, a very nice hardware to analyze very complex stuff, including clinical images. So why kidney research? We have many data. We check a lot of stuff. So we have a lot of good serial data that is available. We have numerical data. So largely we look at numbers, creatinine, UGFR, electrolytes, acid bases. So these are all very important. And with very clear outcomes, like renal failure, CKD, we have a definition. So less than 60 mils for more than 3 months. Mortality, these are all very nice outcomes, the usual outcomes in our kidney research. So in fact, so we fit into a setting that we can make use of AI on very nice modeling to help us to do research. Okay, I'll just show you an example. A study which I've been carrying out with one of my collaborators, how we investigate electrolyte abnormalities in ICU patients and the clinical outcome. So you need a very large body of data. So we collect all the data from ICU patients in Hong Kong throughout the previous 10 years. So there is 180,000 patients. So and we look at their potassium levels. So here we have normal potassium patients are roughly 60,000. Just isolated hyperkalemia, 21,000. And isolated hypokalemia, it's almost like 80,000. And also there are patients of mixed dyskalemia, so meaning that they have a high or low potassium. So you can see that by these are done by the AI. So apart from modeling, we use machine learning and various things to calculate these odds ratio accordingly, and we can determine. So we can see that here the blue bar refers to the ICU mortality, and also we see the red ones are patients with arrhythmia. So this is how we use the very large database and use the various AI models to help us to define out some of we all see a very increased mortality and also increased risk of arrhythmia with different types of potassium levels or derangement. You can see here, we also find a very optimal level of potassium that patients in the ICU that we should keep. So lower than that or higher than that, you have increased mortality. But what here I want to illustrate is that, say, for example, electrolytes, acid base, and kidney function, they're very good clinical parameters for analysis if you use a very big data. So these are all very robust data. And say in the ICU patients, they're very serial monitoring when you get into the ICU, and it's very frequent. So you can always make use of this data. There are other techniques that we use because of the moving windows. There are the AI have to account for that. And with very clear outcomes, for example, mortality is a very clear outcome. So all patients who die in the ICU, they're nicely coded there. But what about soft outcomes? Soft outcomes. So we need very good surrogates. For that one, you need a very sound clinical knowledge and understanding of the usual practice. For example here, if you say arrhythmia, so this wouldn't be coded in the ICU coding, then you have to use a nice surrogate. Here we use, say, the use of anti-arrhythmic drugs in the ICU, for example, like amiodarone, these stuff. So you can use that as a surrogate that these people received a anti-arrhythmic drugs, say because of they have an arrhythmia. So this is a soft outcome. Or perhaps you work on another electrolyte, say sodium. So you want to know whether patients have confusion. So these stuff, it wouldn't be coded unless you go into the records, the details. But there's a surrogate. If the patient had a CT brain done within the ICU stay, which means there is a change in sensorium. So it's a surrogate that there is a change in sensorium. So this might be confusion, this may be seizure. So this is a surrogate. So you can always employ another very trustworthy investigation or drugs to do your surrogate. So this is one of the way how you have to, what you can analyze your big data and also train your AI models. Well, the other area more relevant to us is AI and kidney biopsy. So basically it's pattern recognition. So we have so much on that. During immigration, we go in and out different countries. We try to identify different people, different penguins, whatever. It's a pattern recognition. So I think this is a very hot topic, using artificial intelligence to look at the kidney biopsies, not only with the diagnosis, but also try to have some prognostication or prediction from that one. So we always need a very nice biopsy sample. We need nice scanning. We need a whole slide image for scanning, and then we run the different AI and also the learning models, be it the machine learning or even deep learning. So the most difficult part is to get 2 or 3 slaves. Oh, sorry, a slip of tongue. Not slaves, our PhD students. That's the most important thing. So we need to get people to do annotation. That is the most important. So nowadays online, there are programs that can do automatic annotation. So where are the gloms? Where are the tubules? But that's for this particular project, I want to look at lupus nephritis because my research interest is lupus nephritis. So I asked my PhD student, go to see all these scanned images and annotate all the different components within what we know, the activity index for lupus nephritis, the different components, and also the chronicity indexes for the different components in the chronicity index by the NIH activity and chronicity scores, and then train the system to recognize all these in all the different slides. So this is part 1 of that. And it shows very nice correlation between the trained and the real review by the renal pathologist. And that we can always incorporate these data to predict some of the outcomes of interest. For example, I always want to know kidney recurrence within someone with lupus flare. So when you apply not just the histological data, but also in conjunction with other serial lab parameters. For example, double-stranded DNA, complements. What are the predictive values? You can see a very nice AUC or predictive value in predicting renal recurrence. So there's 0.8, even almost like 0.9, and even up to 10 years, you predict a renal recurrence. The accuracy or the AUC is up to 0.85, so which is a very good performance. And in fact, we can always analyze which component is more important. So in the early part of the follow-up, the renal histology looks more important. I haven't shown you the data here, while in the latter part of the follow-up, the clinical parameters, for example, double-stranded DNA or complements, they have a higher weight in predicting relapse, so which makes sense. And the other thing is that for all these AI, you have to have an explainability. So it's a black box how the computer or the machine or the AI recognize these stuff. So there are explainability analysis to see which of these histological component is more predictive or have a more weight in predicting relapses. So the same applies. So the next step of this is to predict who in lupus nephritis would develop chronic kidney disease or renal failure. So applying the same principle, throwing in all the histological data and also the serial clinical parameters to determine the long-term renal outcomes. What about the eyes and the kidneys? So this is something which I am also doing. We always talk about diabetic kidney disease, a leading cause of chronic kidney disease and renal failure. Probably in different parts of the world, this still holds true. Classically, when I was taught in med school, diabetic retinopathy and diabetic kidney disease, they're always linked. If you see that there's an eye problem within the retina, you always see a problem in the kidneys. You have to see microscopic or macroalbuminuria, and because they're all microvascular complications. So this is what I said in the first slide. There's a link there. So by analysis of retinal images, this could be an invasive means to predict CKD in diabetic patients. So in this project, we analyze a lot of retinal photos, up to 13,000 photos from 3,000 DN patients, and using a CNN network to make analysis to predict their development of CKD. And it shows a very nice ROC curve, 0.8, and with a very nice specificity. So this is another example how we can apply medical image, some of the lab parameters, link them together to predict the renal outcomes. Well, the next part, I'll look at other parts of the body, including the blood cells. Here we see all different morphologies when we study hematology, pathology, which I almost gave it back to my teacher, so the different morphology. But interestingly, it's also done by my collaborators. We look at the different morphology, look at how they are pointed, how wrinkled the cell membrane are, what are the different changes in the cell membrane of different blood cell types within the blood in healthy patients and CKD patients. We make comparisons. So here we found that they look rather differently. You can see the clusters. They look the cluster in the different clusters. So meaning that the morphology of the blood cells, be it an RBC or a peripheral mononuclear cells in CKD patients or patients who are healthy, they are rather different. When we look in more finer details, we found that the RBCs in particular in the CKD patients is very, very much different from patients who are healthy. And in fact, these indexes indicated that the RBC membranes and the morphology, they look really unhealthy. So this forms a hypothesis. We have to investigate further because apart from the renal anemia, apart from being induced by a very low erythropoietin level in CKD patients, the reduced red cell survivals because of all these membrane abnormalities might be another reason. So we are carrying out red cell analysis studies to prove our hypothesis whether these changes in the red cell morphology, in the membrane changes, whether they are associated with the reduced red cell survivals in the CKD patients. And for the same token, we're also working on the white cells, trying to account for why our CKD patients, they have much impaired immune response. So we see very impaired vaccination response. We always see infections in our CKD patients, whether these changes in the white cell morphology or whether they're activated morphology, whether they are easy to be activated, accounts for that. And also whether some of these abnormal activation will account for the vascular abnormality or vasculopathy in our CKD patients. So these are all hypothesis generating. We're not solving all problems with computers, but they're generating nice hypotheses for us to investigate further. Okay, so there are 5 minutes more left. I'll just show you I'll just switch the topic to show you some ambulatory and non-invasive monitoring of kidney function. So here we make use of electricity. So electricity we discovered for so many years. With the kites, we find electricity. We have all the Tesla or everything, Edison. So they all about electricity. But in fact, when you think about it, the kidney is an organ which is very rich in fluids and electrolytes. So with water, with electrolytes, there's a very nice conductivity. So when we get into kidney fibrosis, which is a final common pathway of all forms of different kidney disease, be it acute or chronic kidney injury, all these electrolytes, all these tubules, water-rich substances, they're replaced by matrices and all these fibrotic materials. So, and there's a reduce in bioconductivity. So by measuring the bioconductivity, you can assess or monitor the progression of CKD. And for this reason, I work with another company, or a tech company, to develop a technique called electrical impedance tomography. So where we wear a belt. So it passes different currents, different voltages of currents, different amperes of currents and then to test the conductivity or the impedance from this tomography. So with different receptors all over the belt. So, and see. So this is what we've done. So you can see the left-handmost panel. So there are many electrodes picking up the electrical signals there. And we do analysis, also by some of them by the AI. So these are the EIT raw data. And if you see there's a water, this is a water phantom. It's called phantom. So there's nothing there. So you have nothing there. You see no signal there. And you put an insulator or a conductor, you see two different signals, the red and the green one. And in fact, we also tested we put a pig's kidney there. It's not a xenotransplant, but it's a pig's kidney. So we find a signal there, a very nice blue signal there, and we inject different stuff into the kidney, inject alcohol to sclerose the kidney, and we saw changes in the conductivity. And we also try to work it on human, on around 88 patients. Right now we have 200 patients in this trial. We see the very different conductivity in different stages of CKD, and it shows a very nice correlation with the eGFR. And by calculation and modeling, we can always make an electrical eGFR that correlates with our GFR. So an electrical one is a EIT, I think it's the GFR EIT. So it shows a nice correlation with our measured eGFR by blood tests. So this is one of the encouraging non-invasive modality which I am working on to assess kidney function. So this is just an example how we use technology to help us to monitor chronic kidney disease. And it's also useful for a mass screening in the population. Say if you have a campaign in a certain square asking everyone to do a dipstick or hypertension, and always you can apply the same belt to measure the kidney conductivity to detect early CKD. So this is also another possibility. So in fact, we are making these devices with the company and will soon be out in the market. So just to conclude my talk, kidney diseases are very suitable for AI research because of the reasons I've alluded to you, including that we're very serial, frequent, nice laboratory data, nice outcomes. And the artificial intelligence is a very powerful tool for data analysis in kidney disease, including we analyze the kidney images. For example, biopsy images is a very, very complex image. It's multicolor, multi-structure, multi-pathologic features. And also I show you the retinal images, which is it's a very promising area, and laboratory parameters, and also we need correlations with the clinical outcomes. Of course, in the last part of my talk, I show you that the advanced medical technology can also help the early diagnosis and the continuous monitoring of the kidney function. So by this, I will end my talk, and I'll join the panel if you have any questions. So I'll show you a very beautiful night scene of Hong Kong, so my hometown. Okay, thank you.